What do you think?
Yeah, if there's other people joining a little late, that's okay.
Yeah, I think that we have most of the committee, pretty much a quorum of folks. So I'd like to get our meeting started. I'm Tracy Luce. I'm the Division of Research at Kaiser Permanente, Northern California. And as chair of this study and of this committee meeting, I'd like to welcome everyone. The task being undertaken by this committee of the National Academies of Sciences, Engineering, and Medicine is to assist NIH and AHRQ in filling evidence gaps within the recommendations of the U.S. Preventive Services Task Force. The formal statement of task can be found on the project website and will be discussed at length during this 2-hour meeting. I want to note that this is an open, on-the-record session. Because time is limited today, we'll restrict questions to the invited speakers. We will have more time at subsequent meetings for more robust discussion. I also would like to remind everyone that this is an information gathering session. That is, the committee is in the process of assembling materials that it will examine and discuss in the course of making its findings, conclusions, and recommendations. Therefore, I ask everyone here today to be extremely mindful of the fact that the committee has made no conclusions and that it would be a mistake for anyone to leave here today thinking otherwise. Comments made by individuals, including members of the committee, should not be interpreted as positions of the committee or of the academies. In addition, committee members typically ask probing questions in these information gathering sessions that may not be indicative of their personal views. The committee will deliberate thoroughly before writing its draft report. And moreover, once the draft report is written, it must go through a rigorous review by experts who are anonymous to the committee, and then the committee must respond to this review with appropriate revisions that adequately satisfy the Academy's Report Review Committee and the National Academy of Sciences president before it is considered an official Academy's report. Before turning the meeting over to our invited guests, I'd like the committee as well as the NASM staff to very briefly introduce themselves, including affiliation and relevant work related to the topic at hand. And for the committee members, we'll go in alphabetical order, kind of similar to our initial meeting. So is Kathy Bradley with us? Kathy. And go ahead and turn on your mic. Yeah.
Good morning, Tracy, and good morning, everyone else. I'm Kathy Bradley from the University of Colorado, where I'm the Associate Dean for Research in the Colorado School of Public Health and the Deputy Director of the Cancer Center.
Terrific. Ted?
I'm Ted Ganyitz, a family physician and health services researcher from the University of California, San Diego.
Yen?
Hi, this is Ken Yang Huang, and I'm from NYU School of Medicine, and I'm an associate professor. Thank you.
Preeti?
Good morning, everyone. I'm Preeti Gokul Kochar. I'm from the National Library of Medicine, and I'm a technical information specialist there.
Tianjing? Oh, is Tianjing on? I don't see her. Let's see. We'll move to Venkat. And Venkat, you may need to take yourself off mute.
Sorry. Yeah, Venkat Narayan, Emory School of Public Health and School of Medicine. I'm a faculty there.
Wanda.
Good morning, everybody. Good to see you. I'm Wanda Nicholson from the University of North Carolina, Chapel Hill. I'm a professor in obstetrics and gynecology. I do health services research and direct the Diabetes and Obesity Core at the Center for Women's Health Research. And proud to say I'm a former task force member.
Elizabeth.
Good morning, everyone. My name is Elizabeth Ufili. I am with Morehouse School of Medicine. I'm a professor of medicine and cardiology and chief medical officer for the Morehouse Choice Accountable Care Organization.
That's great. Bob.
Good morning. I'm Bob Wallace, from, excuse me, from the University of Iowa. I'm an emeritus professor of epidemiology and internal medicine, and really pretty busy doing mostly research.
Great. And I'm Tracy Liu. I'm the director of the Division of Research at Kaiser Permanente, Northern California. I'm a general pediatrician. I was a member of the task force from 1993 to 2003, and I'm really happy to be involved in this work. So let me turn to our nascent staff. Kathleen.
Hi, everybody. I'm Kathleen Stratton. I'm a senior study director in the Board on Population Health in the Health and Medicine Division. And I just want to point out something I put in the chat. As Tracy mentioned, time is limited, so we're going to restrict questions from the committee. But anyone else who's observing, if you'd like to put in a question or a comment for the committee to consider later, we welcome that. Thank you.
Great. Alexis.
Hi, my name is Alexis Wodowitz. I'm an associate program officer on the Board on Population Health and Public Health Practice.
And Asia.
Hi, good morning, everyone. I'm Asia Coltrane. I'm the senior program assistant on the Board of Population Health and Public Health Practice.
Okay. That's terrific. So I'm going to just very briefly introduce our first two guests. We have your bio sketches, and thank you so much for being with us. So we're able to read a lot more detail about you. Arlene Bierman is the director of the Agency for Healthcare Research and Quality's Center for Evidence and Practice Improvement. And David Murray is the associate director for prevention and the director of the Office of Disease Prevention at NIH. Thank you so much, and welcome to you. Why don't we go ahead and get started with the first presentation, which I believe belongs to Arlene.
Welcome, everybody. Thank you so much for serving on this committee, and ARC really looks forward to your input. So the U.S. Preventive Services Task Force sits within the Center for Evidence and Practice Improvement at AHRQ. Next slide. So I'm briefly just going to tell you a little bit about ARC, our support to the task force and the impetus for this project and what we're hoping to get out of it. Next slide. So ARC's mission is to produce evidence to make healthcare safer, higher quality, more accessible, equitable, and affordable, and to work with HHS and other partners to make sure that the evidence is understood and used. So I'm mentioning this just so that you're aware that ARC also takes the recommendations for the task force and has another number of activities around implementing the recommendations into clinical practice. Next slide. So ARC provides administrative, scientific, technical, and dissemination support to the U.S. Preventive Services Task Force, and has done this since 1998 when it was authorized by Congress. And the U.S. Preventive Services Task Force is an independent entity, so the recommendations are not coming from the government, they're coming from the task force, and panel members are volunteers. So they do an incredible amount of work as volunteers, and that's what makes the task force work. Next slide. So it's an independent panel of non-federal experts in prevention and evidence-based medicine. It makes evidence-based recommendations about clinical preventive services, including screening, counseling, and preventive medications. And the recommendations address only services offered in the primary care setting or services referred by a primary care clinician. And the recommendations apply only to adults and children with no signs or symptoms or unrecognized signs and symptoms, which is an important distinction. So really the recommendations are about population-based screening. Next slide. So in communicating its recommendations, I'm sure everybody here, I know there's a lot of task force members listening, know about the A, B, C, D, and I statements. But when the task force identifies a gap, they issue an I statement, which is insufficient evidence. And also in the recommendation of all of our recommendation statements includes a discussion of where the evidence gaps are. And ARC is mandated to provide an annual report to Congress where we highlight the priority research gaps each year so that the Congress is aware of these gaps as well. Next slide. So just of the task force 85 topics, the following were posted or published this year. And the task force process is very transparent. So first, there's a draft research plan that's posted, a final research plan is posted, and a draft recommendation for public comment before the final recommendations are posted. Next slide. So the 2020 annual report to Congress this year, and this is available online for anybody who's interested, focused on child and adolescent health and health inequities, and specifically looked at evidence gaps around mental and behavioral health, substance use, and obesity. Next slide. So the U.S. Preventive Services Task Force identifies gaps and disseminates its recommendations, also drawing attention to what the gaps are. Funders and investigators can look at these gaps, and hopefully there's new funding opportunities and new research to close the gaps. And then the recommendations are all updated periodically. Next slide, please. So I wanted to give you a couple of examples, because the good news is it's possible to close these gaps. And really based on the funding by NIH and others, we've been able to convert a number of recommendations to, concrete recommendations over the last year. And as example, in 2005, the task force concluded there was not enough evidence to recommend for or against routine screening in overweight children and adolescents as a means to prevent adverse health outcomes. And then 5 years later, in 2010, it was changed to a B recommendation, advising that clinicians screen children aged 6 years or older for obesity and offer them referral to comprehensive intensive behavioral interventions to promote improvement in weight status. And it was able to make this recommendation because of new evidence on the topic, including studies funded by NIH. Next slide. Just a couple of additional examples. In 2018, the task force concluded there was not enough evidence on screening for abuse, neglect, and neglect in older and vulnerable adults. So to address this gap, NIH is funding several projects to identify elder abuse and the mistreatment of people with physical and mental disabilities. So hopefully in the future, the task force will be able to make a recommendation on this important topic. And in 2003, the task force concluded that the evidence was insufficient to be able to recommend for or against routine screening for tobacco use or interventions to prevent or treat tobacco use and dependence in children and adolescents. But in 2013, when the task force reviewed the evidence again on the topic, it identified new studies, including studies funded by NIH. So they were able to change this to a B recommendation. Next slide. So our perspective on this very important work group is to really support the task force in developing its recommendations, including having new and better evidence to examine when the task force updates topics and communicating its evidence gaps. And multiple organizations play a role. Organizations developing recommendations, funding agencies, and members of the research community. Next slide. So there's a need for a taxonomy and to really be able to, I think, increase the impact of our recommendations. And they need to be actionable to recommendation developers, funders, and the research community. They need to account for the multiple dimensions of evidence gaps. And they need to consider both existing task force methods and innovative new methodologies that could help close the evidence gaps. Next slide. So the hope is that a taxonomy could help stakeholders better understand and use the evidence gaps, assess their relative importance, identify innovative methods to help fill the evidence gaps, and accelerate research that addresses these gaps. Next slide. So in summary, ARC has an important role in supporting the task force to develop and disseminate its recommendations. Multiple organizations play a role in helping identify, fill, and close these gaps. and recommendation developers, for example, the task force funders and the research community all play a role. So I think there's a huge value for an actionable taxonomy and recommendations to be able to really guide how we prioritize and fund research to close the gaps identified by the task force. Thank you.
Thank you so much, Arlene. I think we'll go ahead and go on to David Murray's presentation, and then we'll have questions and discussions after both. So David, may I invite you to, and I think we'll bring up your slides here in a sec.
Do you need me to pull them up, or is someone there pulling them up?
I thought you wanted to share your.
That's fine. That's fine.
Sounds good.
Okay. Now you all should be able to see them.
Perfect.
Yes, forgive me. I'm in too many of these sessions of late, and don't always remember exactly what the plan was that I agreed to. So I want to echo what I just heard from Dr. Bierman in terms of ARC's perspective. NIH has a very similar perspective. I'm going to, here we go. Going to say a few words about our office first, and then I'll move right into the work with the task force. So ODP, the Office of Disease Prevention, our mission is to improve public health by increasing the scope, quality, dissemination, and impact of the prevention research that NIH funds. And most of the work that we do is actually internal facing rather than external facing. We're intent on trying to tinker with the machinery here at NIH to try to help NIH do a better job with the prevention research that it supports. We are located in the Office of the Director. So I wear two hats. I'm the Associate Director for Disease Prevention and report to Francis Collins in that role. I'm also the Director of the Office of Disease Prevention, which is part of the Division of Program Coordination, Planning, and Strategic Initiatives. Jim Anderson is the director of that division. He reports to Francis. So Francis is not too far out of the conversation at any given time. We're one of several programmatic offices within DPKIPSI, along with colleagues in women's health, behavioral and social science, and so forth. All the work that we do in our office is guided by our strategic plan. When I came to the NIH to interview for this position, I asked what the plans were for the office, and the staff looked at me and said, well, we're waiting on the new director to come in and tell us what to do. And that was an interesting perspective. There was no strategic plan. There were no real plans in terms of what the office was going to do going forward. And we've certainly changed that. We have a strategic plan. We're on the second version of it. The next director coming in after, if and when I ever retire, will have something to work from. We have 6 priorities in our strategic plan and 3 cross-cutting themes. The one that I'm going to focus on today is what we refer to sometimes as strategic priority 2, identifying research gaps. The numbers don't mean anything other than that's just the way that they happen to fall in order on the piece of paper when we put this document together. Our office is involved in a variety of activities, again, many of them facing inward. This slide lists a few of the things that we worked on over the last year or so. Strategic priority 2 is to identify prevention research areas for investment or expanded effort by NIH. The IC directors are always interested in hearing from us about things that they might want to pursue or might want to do that will help advance prevention research. They don't want us to tell them what to do, but they're open to suggestion. We partner with stakeholders to identify areas for additional investment. And one of the groups that we work with, I think, quite closely is the task force, working through ARC. There are two task forces, in fact, that we work with, both the U.S. Preventive Services Task Force and the Community Preventive Services Task Force. I saw this as an area early on when I arrived at ODP where we could be very helpful to our agency by drawing attention to the evidence gaps that the task force identifies on a regular basis and trying to help the ICs here develop new research initiatives to fill those evidence gaps. We talked with our IC friends all year long about nominations for task force members, about commenting on the topics that the task force is thinking about considering and thinking about prioritizing. We comment on draft research plans. We comment on draft evidence reports and recommendations. We certainly work with our institute and center friends across NIH to make sure that they're aware of the decisions that the task force is making and the recommendations that they're issuing. Dr. Collins does not want to be surprised. And so one of Carrie's assignments is to make sure that I'm aware of anything that might be surprising coming from the task force, and then I make sure that the leadership is aware of it and prepared to respond to public questions. We're very much interested in the evidence gaps that are identified in the I statements and the other reports that come out. We highlight those on our website. We conduct a survey of all the institutes and centers at NIH each year. We refer to it as the I statement survey because that's what it's about. We provide them, it used to be the whole set of I statements, but there are now so many of them that we do about half one year and the half the next year. So we give them a list of, I think it was 26 or 27 I statements this last time. And we ask them, what are you doing in terms of grants that you're supporting, in terms of cooperative agreements that you're supporting, in terms of contracts that you're supporting, in terms of FOAs that you're developing, in terms of workshops and conferences and so forth. All of the activity that they might be doing that's relevant to any of those I statements. We try to gather all of that information, compile it, prepare a report, which we then feed back to the leadership at NIH. Francis Collins gets the first one, and then all the IC directors get a copy. And I, every year, go to an IC directors meeting and provide a verbal update on what we've seen. Our hope in doing that was that the ICs would take this seriously, would pay more attention to these evidence gaps, and would start trying to generate more activity to fill them. And that has actually been happening. We've been happy with it. We see more and more references to I statements and other evidence gaps coming out of the task force in new funding opportunity announcements, for example. We've had an IC director call and say, David, we'd like to do something to address some of the evidence gaps that you've flagged for us. Can we get together and talk about it and learn more about how the task force works and what they're looking for? So this brings me to the challenges and opportunities for addressing these evidence gaps. They're kind of scattered. They're described in various places. The descriptions are often rather vague. We need, here's an example, we need high quality studies on the potential harms of screening and treatment. That doesn't tell a program officer at NIH what kind of an FOA to put together, what kind of study to call for. It doesn't tell an investigator at the University of North Carolina, Chapel Hill, what sort of application to write, or the University of Colorado School of Public Health. We would like to have evidence gaps better organized and more detail provided as to exactly what kinds of things the task force would need in order to move something from an I statement on. So our goal is to reduce the number of I statements by filling the evidence gaps, but we need more detail on what you're looking for in order to guide our friends here at NIH and our friends around the country out in the extramural community. So we encourage you to propose a taxonomy for describing research gaps, apply it to a sample of existing evidence gaps so you can see how it works, we can see how it works. to characterize particularly the types of studies needed that would help move things along and go from an I to a letter grade. We're very much interested in putting that in front of our colleagues here at NRH and our colleagues in the extramural community. We feel like we have a pretty important role to play in terms of generating new evidence to help fill evidence gaps, and we very much want to do that. The IC directors are eager to help, but they and we are looking for more clarity about exactly what's missing. We used to sometimes send them an I statement report, and they would write back, "Well, David, what is it that we exactly need to do?" And then we would try to fill some of that in. It would be even better if that was coming from the task force directly. I'm happy to answer questions, and I'm sure Dr. Bierman would be happy to answer questions. And I will stop sharing my screen.
Great. Thank you so much, David, and thank you, Arlene, as well. Right before we get started with questions, I'm going to just give a little bit of a pause and welcome the other participants in this meeting. I see many task force members are listening in on this meeting. Thank you so much for joining us. And I see former task force members on as well. It's really a delight to be able to work on this important project for both NIH and HRQ and the task force. I also see Rose Martinez on the meeting, and I neglected to invite you to introduce yourself. So if you are here, go ahead and turn your video on, and would love for you to introduce.
Sure, thank you, Tracy. I'm Rose Martinez. I direct the Board on Population Health and Public Health Practice that this study sits under. Thank you.
Yeah, thank you for being here. So just to reiterate the ground rules for this part of the conversation, as Kathleen mentioned, if you are a committee member, if you have a question or a comment, or would like to be in conversation with Drs. Bierman or Murray, go ahead and raise your hand in the Zoom function. And if you are another participant or a member of the audience, if you have a question, please put it in chat, and we'll be able to get to it. We'll go ahead and give priority to the questions from our committee members. So, and I know this is not a shy committee. So. Okay, Miko, I see you waving.
Yeah, hello. I can't seem to find the raise hand function in the Zoom.
I'm so sorry. Let me coach you.
Raise my hand on the camera.
Yeah.
Yeah, I really appreciate the presentations this morning from both NIH and ARC. My question has to do with when we think about the impact of clinical preventive services, it really ends up being both an effectiveness of the screening when received by the patient, as well as the reach inside or into the population as a whole. And so sometimes the reach into the population goes way beyond the clinic itself. Efforts to make sure that people can actually receive these services. So it could actually be a health plan that has a role in this, or an employer group, a self-insured employer group that wants people to come in for colorectal cancer screening or along those lines of thinking. So my question, or several sort of questions in here, to what degree do you think should our work on this committee look at the role of stakeholders and partners to primary care? That is, how far beyond the clinic should we think? Secondly, how do we consider the overlap between the focus of the work of the US Preventive Services Task Force and the Community Preventive Services Task Force, and particularly in the context of what that may do to the methods that we would deploy to get to some of those answers? So any light you can shine on that would be great.
I'd be happy to take a stab at that. So, Dr. Prunk, those are great questions. the focus of this committee is to develop recommendations about the I statements. How do we, communicate where we don't have the evidence, and how do we close those gaps? There's a whole other portfolio of work. That's why my first slide, I just wanted to highlight what ARC does. And I can give you a couple of examples of what we're doing to increase the reach of the task force recommendations. So ARC is tasked under the Affordable Care Act to disseminate and implement evidence across the US. So for example, the task force recommendation on screening and brief interventions for alcohol. We know that unhealthy drinking is a big problem in this country. We've funded 7 large projects across the state to implement the screening and management of unhealthy drinking in primary care. And we hope to close the gaps around implementation and how do you spread this more widely. So that's something that we take very seriously. And then in terms of the linkage, I agree with you. The way we close this gaps is both through, population health interventions as well as clinical preventive interventions. I'll defer to the committee on the role of the community preventive task force, but we're very excited. We're about to announce 4 state level grants addressing tobacco cessation and hypertension control. And we asked the states to partner with public health agencies like their state health department, Medicaid agencies to align, and we're working closely with the CDC because we think to increase uptake, it'll be more effective to align the interventions in practice, the clinical preventive services with the population-based interventions.
I can try to speak to Nico's question. Should the task force go beyond primary care? That's not really something for NIH to weigh in on. That's, I think, set by statute. We very much value the authority that the task force got in the Affordable Care Act to require insurers to cover the cost of services that get letter grades of A and B. It's that kind of clout that really makes it easy to get institute and center directors to pay attention to evidence gaps related to those recommendations, because they realize that they can move things along for the country in terms of healthcare by filling in some of those gaps. We wish that the Community Preventive Services Task Force had similar authority, but they don't. I know that the 2 task forces do try to coordinate. Dr. Klabunde, who's on this call, and others on our staff attend meetings for both and try to stay in touch with what both groups are doing. But I'm able to get a lot more traction for issues coming out of the U.S. Preventive Services Task Force with my IC directors than I can with the Community Preventive Services Task Force because of the Affordable Care Act and the authority that it gives you. I'm not sure, Nico, if I've answered your question, but I wanted to share those thoughts.
I appreciate that. Maybe a little bit more insight on the methods impact. One of our state tasks, it does indicate you're interested in the types of research studies needed. And I'm wondering, as we get people to be more, to find more access to clinical preventive services, the further we go from the clinic, if you will, the deeper into the community, the methods of research may change dramatically. So do you have more insight on that particular area of focus?
Well, certainly NIH is open to supporting dissemination implementation research to help spread interventions that we know work so that they have broader reach. If this committee comes back with guidance that you need to see additional dissemination implementation studies related to some of these evidence gaps, then that gives us ammunition to go to the IC directors and say, hey, this would be helpful. So you actually have a role to play there. Things that you point to as important for the task force, that gives me ammunition to use in my conversations.
Thank you. That's very helpful. Appreciate that.
Yeah, that is very helpful. I see Wanda waving her hand. Actually, just before Wanda speaks, if you are a committee member and you're looking for the raise hand function, look under participants, and then at the bottom left, there is a blue raise hand function. But it's okay to put your video on and wave as well. So maybe we'll look at Wanda Nicholson.
Yeah, thank you, Tracy. I wanted to go back to the conversation or switch a bit more to the conversation around the taxonomy. So when you're saying that the IC directors need to see or hear more from the I recommendations and the specifics, so are you saying then the specifics in terms of study design, outcomes? Is it a matter of going back to sort of the, I guess, the evidence framework that is largely a part of the evidence-based reports, to use that particular diaphragm or framework as a working start? I guess I was trying to get a better idea. I understand what you're saying in that the statements might be vague about what research is needed. It's not clear that when the IC looks at what is written, that they're able to really walk away with, well, what should the next RFA really say? What should it really be about? So I get that need for clarity. Yeah.
Yeah, that's what we're looking for, is as much specificity as you can offer in terms of the kinds of study designs that would be helpful, the kinds of populations, the kinds of outcomes, the kinds of data. They're really looking for specifics so that the people that are going to write the next FOA are able to write one that provides the information that you're looking for.
Thank you.
Great, thank you. I see Ted Ganyetz with his hand raised. Ted.
Yes, I want to also thank David and Arlene. And Arlene, hi.
Hi.
The process that the task force undergoes is to take some evidence that has been created and out in the world, and then they do their mumbo jumbo. No offense intended by minimizing that. I realize that's key, and then they produce the report. And sometimes the I statement, which is what I am now understanding is the key for what we're doing, could be because of a cognitive problem by the task force in balancing risks and harms. When they look at it, they do not see a preponderance of risks or harms, and so they are not able to make a determination. And so they say that there's insufficient evidence. Or it could be assessing certainty, so that it seems, in reading some editorials, that some people who don't like what the task force has said, that sometimes it might not be a lack of evidence, but might be a cognitive problem on the part of the task force. Now, having done this kind of stuff and been involved with the task force a lot, I understand that this is not common. But the question is, should we solely look at the input, the evidence that has been created by researchers that the task force looks at, or are I statements causes of I statements, which might be the cognitive burden that the task force has to undergo when looking at assessing certainty, balancing risks and harms? Could that also be part of what the taxonomy looks at in the creation of an I statement?
I would say yes, from our perspective. We're looking for as clear a guidance as possible as to what the task force needs, what's missing to be able to move something from an I to a letter grade. And it can be, we don't have enough evidence on harms. It can be, and here's the kind of study that we need to generate the kind of evidence that's missing. It could be, geez, it's kind of mixed here. We've got some stuff pointing one way, some stuff pointing another way. That's just, it's not very certain what additional studies would be helpful in that situation. It's going to vary depending on the circumstances, but you'll hear me say at least 100 times a day, specificity and guidance is what we're looking for.
So I would like to say that, sitting in on task force meetings, they weigh very heavily. They get comprehensive, systematic reviews and weigh very comprehensively the benefits and harms. And there's a lot of misunderstanding about the I statement. There's two different types of statements from the task force, and forgive me, everybody who knows this already, but there's the I statement, which is insufficient evidence. And there's a D statement, which means the evidence is that you shouldn't do it, that the harms outweigh the benefits. But for the I statements, it's not saying clinicians every day in almost every patient have to make decisions in the face of insufficient evidence. So we're not saying don't do it, but it's saying what the state of the science is. Where other guideline bodies are willing to, make that leap and say, we believe people should do it because of all these other extraneous, other considerations. But I think the task force role is just to say, this is what the science tells us now or not, and then provide the guidepost for how to move forward and close those gaps. The one area that I just want to mention where there's a lot of gaps is in terms of subpopulations, especially issues of race and ethnicity, age, older adults, children. So, what do we need to do to specifically close the relevant gaps, and make sure that we're inclusive and have the evidence on where there may be differences across populations or ages?
And to the extent that you can name the subgroups that you need more data on, that provides very clear guidance to folks at NIH in terms of where to go next. NIH right now is very interested in health disparities and minority health, and if there was ever a time to say, hey, we need more work on these subgroups that haven't gotten enough attention in the past, this is an excellent time to do it.
Great, thank you. I'm going to look at Bob Wallace. Bob.
Hi, good morning. Let me say that, like Tracy, I was a member of the task force in the 90s and have substantial experience with it. I thought it was great, by the way. I mean, it was really a growth experience for me. And I really enjoyed it in so many ways, and I still touch both of the task forces. But my question has to do with just forward planning as to how you see where the evidence is or isn't, and I just want to try to do this simply. I was looking at the what might be the last publication, November 24th in JAMA, about behavioral counseling for cardiovascular disease. And so the gaps, evidence gaps are things like sample size and better trials, and all of that is fine. And of course they need to be done, and I don't quibble with any of that. But I'm wondering, looking at gaps in sort of a larger context, maybe the intervention mechanisms themselves, even with the best evidence, are just not that good. Okay, so you might only be able to change behavior and say physical activity 20% of the time, and that leaves a lot of people uncovered, if you will. And I'm wondering, as a matter of policy, then, do you look in a place for other interventions, better interventions, or go back to the lab? I'm just trying to see where the focus is when you say evidence. That's for both of you, recognizing that you are not the task force per se. I hope that's clear enough.
Arlene, did you want to speak to that, or should I start? You're on mute, by the way.
Why don't you start, David, and
Okay.
I'll add.
All right. So I'm a behavioral scientist originally, gradually became an epidemiologist. Now a lot of people think I'm a statistician. So I've played different roles over the years. Changing behavior is not easy, whether it's each of us individually or certainly trying to do it in a population. It's hard, and those interventions are challenging and often fail, or they have modest effects. And many of the things that the task force is interested in involve that kind of intervention. If part of what is keeping you from moving something from an eye to a different grade is that the strength of the effect is just modest or not very strong, then please say so and encourage research on other kinds of interventions that might have bigger effects if that's the problem. You know, policy interventions can often have bigger effects than interventions aimed at individuals, but that's hard to generate out of primary care. So that doesn't seem to be an option. But we're open to any guidance that you want to provide, including, you know, there seem to be very limited effects with the strategies that have been used to date. It might be time for some new strategies.
Yeah, I will add to what David says. So, you know, the task force has its specific role, and clearly we need more evidence on behavior change, but also behavior change on practitioners and practices. How do we get them to do the things that are recommended? And in our D&I work, which is also, you know, mandated under the ACA, initially, we were looking for interventions where there was strong evidence for the interventions. And then the second hoop was that there was strong evidence that you could actually change practice. And what we quickly learned is sometimes that's available, but most of the time it isn't. So the example that I gave before about our unhealthy alcohol use, what we decided to do is, first of all, to use it as a model for the need to integrate behavioral health in primary care and what works to do that. You know, sometimes, and there's systems level interventions as well, like practitioners need to know, you know, where to go if what they've tried in primary care doesn't work. So they need those, you know, shared care and collaborative care, step care arrangements. And what we're doing with these grants is they're expected to increase, you know, both the uptake, you know, of screening and brief interventions, as well as management to what the extent they could do in primary care of alcohol misuse. But at the same time, each of the grantees is testing their strategy for practice change. So we need a lot of evidence on, you know, how to actually, you know, close that last mile and get this evidence used, you know, regularly in practice. So that clearly would be, you know, something we'd be interested in. It's not necessarily the task force, but ARC could play a role in closing some of these gaps in terms of how to move the needle within primary care practices to be able to implement and increase the uptake of the evidence.
That's great.
Thank you.
Yeah, thank you. That's very helpful. Venkat, I see you've had your hand raised for a while, and go ahead and take yourself off mute.
Thank you very much, Tracy. I've got a couple of somewhat philosophical questions to raise. And let me use an example that is very dear to me. I mean, firstly, several years ago, when it came to screening for obesity and evidence for weight loss, the task force used the body of research for diabetes prevention from diabetes prevention trials and concluded that there was very strong evidence for measuring obesity and for implementing weight loss. But the same committee used the same body of evidence when it came to evaluating screening for diabetes and concluded that there wasn't sufficient evidence at that time. So my question really is twofold here. Number one, while we think of evidence assessment as a very objective process, there is a strong element of cognitive dissonance involved. largely around which outcomes we privilege. In the case of obesity, the committee was happy to privilege a metabolic outcome like diabetes, but when it came to diabetes prevention, they wanted an outcome such as cardiovascular disease prevention as the outcome. So that's my first question. So what type of outcome should we privilege? One might argue, for example, 20 years ago, I would have argued that screening requires evidence for the benefit and costs of a hard outcome. But increasingly, I'm beginning to see screening as a process outcome to open up the areas for better implementation. So again, that's one question. So what should be the level of outcome or the type of outcome we should be thinking of? And secondly, that's also intricately related to study design. We all love to think of the randomized controlled trial as the ultimate gold standard of evidence, but many potential interventions, particularly in primary care, may not be amenable to randomized controlled trials. I mean, especially in the area of screening, for example, many of those situations may not be amenable. So how do we, balance? So we might gain on internal validity, but lose a lot on generalizability by focusing on randomized controlled trials. So how do we, these are the two questions. What should there be a taxonomy for how we pick and privilege the right kind of outcomes? Because depending on that, you get different answers. And secondly, should we continue to have the hierarchy of study designs, or should it depend on the context?
It seems to me that both questions that you're asking, one related to outcomes, one related to study designs, these are decisions that the task force makes. I can certainly offer my own individual thinking, but it's really the task force that decides what are the outcomes that they're going to pay attention to for a given situation, and what are the designs that they're going to pay attention to for a given situation. What we're asking is that the taxonomy make clear the kind of outcomes that you're looking for, the kind of study designs that you're looking for, so that we can work with our friends at NIH to try to support research that will generate those kinds of data with those kinds of designs. We haven't. I haven't wanted to go to the IC directors and give them my own personal opinion for what sort of outcomes and designs they should use, because if that's not going to be acceptable to the task force, I haven't accomplished anything. I'm just wasting time. So the task force has not invited me to offer my opinions on these questions, and so I'm kind of. This seems like it's the territory of the task force, not the territory of NIH. That may not be very acceptable, Venkat, but that's my response.
Yeah, I'd like to comment on the research designs, because I think that's critical, and I think that that's something that this committee could do. So we're increasingly in our funding announcements around implementation. I don't think the traditional RCT is an effective, method for studying, complex interventions in complex settings in complex patients. And a recent example is, PCORI funded a large STRIDE trial that was published in the New England Journal that was negative. And when I looked at it from an implementation perspective, it was an elegant, well done, trial by brilliant people, but they didn't address context. They didn't partner with the practices. So I wasn't surprised that they had a negative outcome. And in our funding announcements, we're more and more encouraging alternative designs, rapid cycle, adaptive trials. What kind of science do we really need to do to close these evidence gaps? So, while I can't speak for the task force, I could say that for ARC, we'd love the guidance on what do you recommend? What are the study designs that we should use to fill some of these evidence gaps?
Yeah, I'm generally a proponent of randomized studies. Don't have to be traditional RCTs. Most of my time is spent with group randomized trials, or step wedge designs, or individually randomized group treatment trials. There's lots of variations. I like those. They're not always appropriate for the circumstances. We have some very strong methods that don't involve randomization. regression discontinuity designs. There are others. So I tend to be pretty open when it comes to methods and designs, and try to think about what's appropriate for the situation, what's going to answer the question. But it's up to the task force to decide, what evidence are you going to take as sufficient in order to move something from an I to a different letter grade. And as much as I might be enamored with a regression discontinuity design or something else, if the task force isn't going to attend to it, I don't want to recommend that to NIH.
So I'm going to take the chair's prerogative and make a friendly addendum to Venkat's question. I think that perhaps Venkat is asking whether the taxonomy that this committee forms should attempt to assist the conversation about the study designs and the outcomes of interest.
That I think would be very helpful.
Yeah. Okay. I'm actually keeping an eye on the time. I see that Wanda Nicholson has a hand raised, and I think that may be either the last or the second to last question. And just for Tianjing Li, I just want to give you a heads up that we'll invite you to introduce yourself right before the next session. Okay, Wanda.
Yeah, I'll make it quick. I had two follow-up questions. One is part of the scope, or has a thought been given to the taxonomy, including some type of input on sort of the priority of the different research that the task force would need? So if you're trying to go from the I to the B, or I to B to A, and you have this area that you've written about what type of studies you need. When I say about a matrix, more of an impact matrix, where you're looking at amount of effort or dollars, or what I guess I would say effort in terms of research and the impact. Whether there's lesser effort needed, but could still be a higher impact versus more effort and a high impact. Should that be part of how the taxonomy may help the task force to better organize the section around what they need to move off the I? And then my second question is from a little bit different perspective, but based on an earlier comment, when we are talking about what is missing, sometimes what is missing goes further back than the best cohort study or the RCT. It may sometimes go back to somewhat, do we have an intervention that really captures the underlying mechanisms of a disease or a disease process? And I guess in terms of thinking about the taxonomy, how useful is it for the task force in the future to reference that or allude to that as well, which is a bit more of the translational research versus what I think we might think about more on this call in terms of epidemiologic health services, research, dissemination, and implementation. So sort of two different categories of questions I'm asking.
Certainly it would be helpful to NIH to have, as part of the taxonomy, some indication of the effort likely to be required to generate the evidence. We can make our own assessment of that, but having that come from the task force would be helpful. In terms of the intervention and mechanisms, the best interventions are those that directly address the mechanisms that connect the inputs to the health condition later. So if the task force or the taxonomy asks for clear links between the intervention and the mechanisms, that's then something that we can pass on to FOA writers and to the extramural community and ask them to do that. So again, all of those things contribute to being more specific about what you're looking for, what the task force is looking for, and would be helpful.
Caroline, did you want to add anything to that? We'll give David.
Sorry, I don't have anything to add. Thank you.
Okay. That's terrific. So thank you so much to Arlene Bierman and to David Murray for coming and helping us get off to a great start with this committee. It's really enlightening to have your perspectives, and I think it's helped us all a lot to be able to hear more from you about what our sponsors are looking for. So
thanks for taking the time to listen.
Yeah, that's
Yes,
great.
thanks for taking on this project. Thanks very much.
We're all very excited about it. All right, before we switch gears, let me look at Tianjin Li and invite you to introduce yourself, Tianjin, as one of our committee members.
Hi, I'm sorry I had another conflicting meeting at the same time. So I'm associate professor in the Department of Ophthalmology at CU Anschutz Medical Campus. I was trained as an epidemiologist, and my research interest is really the methodology for clinical trials and systematic reviews. Thank you for having me on the committee.
Great. So we are going to switch gears. We actually have 3 speakers for the next session, which is a 1-hour session. And actually we have the first 2 on the role of the U.S. Preventive Services Task Force. So I'll introduce our first 2 speakers. And then last but not least, we will have Carrie Klabundi for the role of NIH. But let me look first to Amanda Borski and to Carol Mangione. So Amanda Borski is the program manager for the U.S. Preventive Services Task Force Division at the Agency for Healthcare Research and Quality. Welcome. We know you have a busy job. And Carol Mangione is the vice chairperson of the U.S. Preventive Services Task Force. In her day job, she is also the chief of the Division of General Internal Medicine and Health Services Research, and the Barbara A. Levy and Gerald S. Levy Endowed Chair in Medicine at the Geffen School of Medicine at UCLA, as well as the Department of Medicine Executive Vice Chair for Health Equity and Health Services Research there. So Amanda and Carol, thank you so much for joining us. We are very much looking forward to hearing from you about the role of the U.S. Preventive Services Task Force. Would you like to go ahead and put up your slide?
Great. I think they're pulling up right now. Terrific. Well, thank you so much for the opportunity to talk with you all today. We're really excited for this committee and the work that you all produce. So thanks so much again for having us. So my name is Amanda Borski. I'm the program manager for the Task Force Division, and I'll be co-presenting with Dr. Mangione, who's our vice chair for the U.S. Preventive Services Task Force. And we're going to be talking about the role for the task force in identifying evidence gaps. Next slide. So I'm going to start off by just providing a brief background on the U.S. Preventive Services Task Force, just in addition to what Dr. Bierman's already talked about, giving a little bit of an overview of the task force methods and some of the dissemination strategies. And Dr. Mangione will talk about the evidence gaps and give some real examples from the task force. Next slide. So I always just like to give a sense of kind of where we're headed and what we hope you might consider as some of the main takeaways. And so I think it's really important to think about the mission of the task force and its mandate, which is to develop and disseminate recommendations on clinical preventive services. The scope of the task force is fairly specific. In doing that, the task force uses rigorous methods to develop its recommendations and uses transparent and systematic methods to do so. For all recommendations, not just the I statements, the task force identifies evidence gaps. And I'll talk more about that because there are some differences in there as well. The task force looks to other organizations like clinical professional organizations and federal agencies to play a key role in disseminating the task force's recommendations and helping fill evidence gaps. There's multiple stakeholders that are really critical to this process. And both the task force and ARC hopes that the taxonomy will be actionable and beneficial to the task force as well as those other stakeholder groups to help generate evidence and address evidence gaps. And next slide. And one more. So, in terms of the task force, it's looking at existing evidence, so existing published scientific research. It's not conducting its own studies. Whenever the task force looks at a topic, it is evaluating the benefits and harms of each service, and so that it can assess the overall net benefit of the preventive service. And as Dr. Bierman already noted, the task force is focused on the primary care setting and for asymptomatic populations. Next slide. In terms of the members of the task force, again, they are volunteers, and the task force and its recommendations are independent. So while ARC does provide scientific, technical, and administrative and dissemination support, which includes funding the evidence-based practice centers who independently conduct the systematic review for the task force reviews that evidence, considers it, weighs the benefits and harms when it comes up with its independent recommendation. Next slide. And one more. So just going into some of the methods, and you'll see on some of these slides at different places referencing the task force procedure manual. And just given time constraints, I'm just going to touch upon these as some high points, but the procedure manual really does provide a lot more details about the types of studies and the processes that the task force does use. So really do encourage further examination into that as well. In terms of the task force's recommendation development process, I'm sure many of you are already familiar with this. There's 4 stages to it, and all of the drafts are always posted for public comment period. So, just as a quick, note about that, if anyone is looking at a draft research plan, which lays out the analytic framework, anyone can provide feedback and public comments on what other factors the task force may want to consider. So to start out, once a topic is identified, the task force will develop a draft research plan. And again, that lays the analytic framework and blueprint for the types of studies that the task force is going to look for. It will talk about the populations, the outcomes, the key questions. And I'm going to talk a little bit more about this shortly. There's a 4-week public comment period. The task force reviews all those comments, considers them, finalizes the research plan, so that way the evidence-based practice center can do the systematic review according to the plan. The evidence review is then presented to the task force. The task force will deliberate and weigh the evidence on the benefits and harms and come up with its draft recommendation statement. Both the draft evidence review and the draft recommendation statement are also again posted for that 4-week public comment period. Task force takes the time to review all of the comments that will come in and then finalizes its recommendation. Next slide. So this slide shows the task force partners, and I show this here for several reasons. One is, again, to show the many stakeholders that are involved in the process, but also to show the importance the task force places on its partnerships with these organizations, including the National Institutes of Health. So as you can see here, some of these organizations are those that deliver primary care services like AEFP. And then there's also research funders and federal partners, including NIH. And so the task force regularly works with these organizations to encourage their input to all drafts, to get their input, make sure the task force is considering the evidence and weighing things in the right manner to get that input. But then also when the task force has a final recommendation, to help disseminate it. And again, in all final recommendations, there is information on evidence gaps. So again, the task force views this as part of kind of its process where task force will identify gaps and then work with others, including NIH, to hopefully help address the gaps. Next slide. And so here, as Dr. Bierman touched on, are the recommendation grades. And again, the task force comes up with each grades based on the certainty of how they weigh the balance of benefits and harms. So the A's and B's mean to offer or provide the service. A C means to offer or provide it for selected patients depending on individual circumstances. A D means to discourage the service. And the I statement means the task force was not able to assess the balance of benefits and harms for the service. So more research is needed. So the I statement signifies an evidence gap for overall for the preventive service topic. But again, even within the graded recommendations, there can still be, and there are still evidence gaps that the task force will identify. And one just additional note that had come up in some of the earlier questions about the I statements is that the task force does try to explain why it's an I statement in the rationale or assessment section, where the task force goes through how it weighed the certainty of the evidence for each of its criteria. And that's where it really will try to say, was it due to lack of evidence, an inconsistent finding, studies being underpowered, whatever the rationale for the I statement may be. Next slide. So again, here I'm going to try to go through a little bit more in methods, but just at a very high level. And so this is an example of an analytic framework, which is part of all task force draft research plans or all research plans. Again, this is really the blueprint for what types of evidence the task force is going to consider. So in terms of the earlier questions, what study designs will the task force consider? What outcomes will they consider? This is always pre-specified at the very first stage of the task force's recommendation development process in the research plan as part of this analytic framework. And so this example is a template for a screening topic, but the task force does also have similar but slightly different versions for counseling topics as well as preventive medicine. So just to kind of walk briefly through this. So on the left, you can see the persons at risk. That's the population. So who is the task force looking for evidence on? You can see numbers. These represent the key questions that are going to be part of the evidence review. So the questions that will be systematically reviewed. And these are the questions that the task force is going to need evidence on in order to make a recommendation. On here, you'll see both what the task force calls the direct evidence pathway and the indirect evidence pathway. So for direct evidence, you can see that with the number 1, or often it's key question 1, which is looking for direct evidence between screening and the health outcomes that are measured. And traditionally, this is often done through rigorous randomized controlled trials. And again, the task force is always looking at the health outcomes and the benefits of those. There's also the indirect pathway, which the task force can look at as well, and that's looking at the linkages in the chain of evidence between the preventive service and the health outcome. So for example, this would require the task force to look at the linkage between the accuracy of the screening tests, the efficacy of harms in early treatment, and then the association between the intermediate outcomes and the health outcomes all the way on the right. The health outcomes, again, just to stress, that is where the task force needs to see some evidence on to look at the benefits or harms for those. And some examples may include visual impairment, pain, functional status, quality of life, or death. And the health outcomes, the task force defines as those conditions that patients can feel or experience. You can also see the task force can look at intermediate outcomes, but those alone are not sufficient for the task force to make a recommendation. And so intermediate outcomes are those that are pathologic, physiological, psychological, social, or behavioral measures. Some examples would include blood pressure, cholesterol, vitamin levels, educational achievement, or hospitalizations. Next slide. In terms of the study designs, the task force does view as kind of the gold standards, as many have already talked about, as the randomized controlled trial, but recognizes that study design is not always feasible for various topics. So there are other study designs that the task force can and does consider as part of routinely when it's looking at the evidence. And again, for each topic, it will pre-specify what study designs it will consider in that research plan. Next slide. So for each study design, the task force has some criteria for assessing the internal validity of the individual studies. And so here it's just trying to show an example for randomized controlled trials as well as cohort studies of the criteria that the task force would be looking at and considering. And the task force does recognize that methods are evolving and really wants to use the most advanced methods possible. So these are intended to be high level because the task force doesn't want to be prescriptive. It knows that methods can evolve and wants to be responsive to it, but these are things that the task force will be considering when it assesses the quality of the evidence. Next slide. And similar here, these are some of the criteria for diagnostic accuracy studies. And again, really trying to show these because as we've heard, there's a desire for the task force to say, well, what kind of study should be done? And the task force intentionally doesn't want to be prescriptive because there often isn't a one-size-fits-all solution to that, but there are different options available to researchers. But in doing that, there are some key principles that the task force will suggest that researchers follow so that way they can have good quality evidence when reviewing it in the future. Next slide. Also want to touch on, in addition to looking at the findings from a systematic review, the task force can commission modeling to support its recommendations. The task force is only going to use modeling when there's direct evidence or indirect evidence of the benefit of the preventive service. So there's already empirical evidence that the task force is going to make this recommendation. It would then use modeling to fill in select gaps. And often this is done for when to start or stop a preventive service, or to try to figure out how frequently to recommend the preventive services. And so traditionally, this is often used for some of the task force's cancer screening recommendations. And next slide. And so my last two slides before I turn things over to Dr. Mangione is just to show a little bit about dissemination strategies. And for within the task force's recommendations, there's various products that the task force will produce to help get the recommendations, including the evidence gaps, to various stakeholders. And the clinical audience and primary care clinicians are the task force's primary audience based on its mandate. But again, there are many other audiences the task force does try to serve, including patients, including the research funders, the research community, and the general public. And so when putting out its recommendations, they're always posted on their website, and people can sign up for email listserv notifications to help reach clinicians more so with the recommendations. The recommendations are published in JAMA and also included in an app now called Prevention Task Force. It was formerly called EPSS. That's really an app designed for clinicians. For patients, the task force does produce always a plain language summary of the recommendations, and the task force recommendations are included in the website called Health Finder, which is a tool more for patients to help figure out what preventive services are right for them. And also in terms of the media, which helps as a channel for getting the recommendations out to all those various stakeholders, the task force does put out news bulletins to summarize the recommendations. And last slide. So this is about 2 years ago in 2018, the task force embarked on an effort to make some changes to the structure of its recommendation statements. And this was not changing the methods in any way, shape, or form. The methods were consistent, but it wanted to update its recommendation to make sure it was following best practices of communication. And some of the goals when it embarked on these revisions were to make sure it maintained being consistent with national standards and also was clear and helpful to clinicians in practice. It conveyed trustworthiness through transparency, and that it continued to describe the evidence for which the recommendations were made and any gaps that were found. And again, stressing there's no changes to methods. This really had to do with more formatting, structure, and organization. The task force looked at various literature, had a series of key informant interviews with individuals to help inform these changes. And two, I just want to highlight here. The first one is the research needs and gaps section. Again, this has always been a section of all task force recommendations, but as part of the revisions 2 years ago, it was pulled out into a primary heading level to help make it draw more emphasis to it, and also some additional guidance in terms of what goes into that section. Again, formatting and stylistic, but now they're using bulleting to really help group the gaps and to help hopefully make it a little bit more clear to the audience. The one other thing just to note is that in the assessment of magnitude of net benefit section, which used to be known as the rationale section, that is where the task force really tries to communicate why the recommendation is a certain grade or why it's an I statement. So really trying to point to that as they go through the evidence criteria. And next slide. And so now I'm going to turn things over to Dr. Mangione.
Thank you. Next slide, please. So I'm going to talk a little bit about different ways that something may become an I statement. So as you've heard already, that the task force will issue an I statement when the current evidence is lacking or of poor quality or conflicting. We also will use an I statement when the evidence is insufficient. So we're unable to assess the benefits of balance and harm of the preventive service. Right now we have 54 I statements. Included with the recommendations, as Amanda has noted, we try hard to point out very clearly where the gaps in the evidence remain in this new section that gets a section header of its own called Research Needs and Gaps. And we have 85 recommendations with 136 specific grades. All evidence reviews examine whether there are populations or subpopulations that have higher prevalence or experience greater morbidity or mortality from the condition of interest. And as you'll see on my subsequent slides, oftentimes these are the precise populations where we may lack evidence. Next slide, please. So an I statement may pertain to an entire recommendation, such as the topic of screening for celiac disease in 2017. Or, and I would say probably more commonly in my experience on the task force, to a subset of the recommendation, such as aspirin use to prevent cardiovascular disease and colorectal cancer in 2016. In this situation, we issued an I statement for adults aged 50 and younger and over age 70, but a B statement for adults between 50 and 59 with greater than or equal to a 10% 10-year risk for cardiovascular disease, and a C statement for adults aged 60 to 69 with greater than a 10% risk. One can only imagine, as a busy primary care doctor, how challenging it might be to accurately implement this recommendation. Next slide, please. I would like to move to talk a little bit of how health equity provides a context for some of the challenges with our I statements. So the Uspstf needs quality evidence about the benefits and harms of a service and about the way specific population groups are affected. And oftentimes this is missing. Examples include age groups, children, older adults, racial and ethnic groups, such as Blacks, Latinx people, American Indians, Asian Pacific Islanders, and others, or people who do not identify as heterosexual. Oftentimes, those disproportionately affected by social risk factors, such as financial strain or lack of access to affordable or nutritious food, have an overlap with some of these other groups, which adds additional complexity when thinking about how a given recommendation may influence either intended or unintended health equity issues. Next slide, please. I'm going to provide you with an example from a health disparity. The evidence reviews include identifying populations that have higher prevalence or experience greater morbidity or mortality from a condition. But as I've mentioned, the evidence is oftentimes lacking to inform recommendations that can address gaps identified for specific groups who are disproportionately impacted by the condition. And I would like to walk you through our examples of screening for lung cancer and screening for colorectal cancer. These are draft recommendations. Next slide, please. So let's start with the screening for lung cancer, which is currently in draft form and has a grade B. The research needs and gaps are as follows. We need implementation research to address how to increase the uptake of lung cancer screening discussions in clinical practice, particularly among minorities and vulnerable populations. Research is needed to evaluate whether, as lung cancer screening is implemented in diverse community settings, including those settings with racial and ethnic minorities and among socioeconomically disadvantaged groups where smoking prevalence and lung cancer incidence is higher, and in settings where screening greater numbers of women and the balances of benefits and harms differs potentially from what is seen in the randomized controlled trials. We also need research to identify biomarkers that identify higher risk persons for lung cancer, and that identify technologies that more accurately discriminate between benign and malignant lung cancer nodules. We also called out that research is needed on the benefits and harms of using risk prediction models to select patients for lung cancer screening, including whether the use of a risk prediction model actually creates a barrier to wider implementation of screening in primary care. Next slide, please. Our annual report of the evidence gaps goes out to Congress every year, and that has been emphasized already today. This year's annual report focused on child and adolescent health and health inequalities. Next slide, please. We'd like to provide some general guidance for how to fill the gaps. We need to examine preventive services conducted in the primary care setting or that which is referable to primary care. These need to include populations most affected by the conditions of interest, including populations without obvious signs or symptoms of the condition, as noted before. These studies need to adopt rigorous designs appropriate for the question, such as randomized controlled trials or high-quality observational studies. As mentioned by Amanda, the Uspstf may also commission modeling studies, and these are oftentimes critical for understanding when a screening test should be started in an adult population, how frequently it should be repeated, and when it should be stopped. We need to compare outcomes, health outcomes, for screened versus unscreened populations. And these studies need to be free of potential sources of bias, such as high dropout rates among participants or biased assessments of outcomes. Next slide, please. You have seen this figure, and we've really adopted this as a model. Our role on the task force is to identify gaps and to make dissemination recommendations. But then it's really up to the funders and investigators review and to create new funding opportunities and new research. We then can take that research and develop and update recommendations. Next slide, please. So just to summarize and a recap of the project goals. The goals of the evidence gaps taxonomy are to provide immediate and long-term solutions that will help organizations that develop preventive recommendations, such as the task force, to more clearly communicate existing evidence gaps. We'll also help funding agencies, including the NIH, to understand, assess the relative importance of and use of evidence gaps from preventive service recommendations in order to ultimately support research that fills those gaps. It will help members of our research community to focus their research on high priority areas that have evidence gaps, and ultimately all stakeholders, including patients, to bridge the translation of the evidence gaps into funding opportunities and other initiatives that ultimately use innovative methods to close those gaps related to the use of clinical preventive services. Next slide, please. We have a lot of challenges. We need to describe the gaps in a way that is clear but flexible for the various approaches that can be used to fill the gaps. Multiple organizations play a role in filling evidence gaps, and the mission of the task force is to develop the recommendations, taking the information that's provided. There are evidence challenges. We have to balance innovation with replication in studies. And we need to examine health outcomes, or we need to be able to firmly connect intermediate outcomes with health outcomes to be able to get to robust recommendations. Next slide, please. So the mission is to develop and disseminate recommendations on clinical preventive services, to use rigorous methods to develop those recommendations, including the type of evidence it considers, to identify gaps in evidence in all recommendation statements and evidence reviews, and to look to partner organizations and agencies to play key roles in helping to fill those gaps and to support dissemination and implementation. The task force recognizes that we may need to move away from the thinking of a hierarchy of evidence, the way it's been described by other speakers and questioned in this session. We have a lot of new data out there and new approaches for how to analyze observational data coming from electronic medical records and other sources. And the task force recognizes that there may not be sufficient resources or time to repeat clinical trials in some of the most at-risk groups, and that we're going to have to turn to other potential innovative methods and incorporate those into the draft recommendations as we try to fill these evidence gaps, especially the gaps that are driving health disparities. Hopefully a taxonomy can provide immediate and long-term solutions for all of us stakeholders who are in this meeting. Next slide, please. Thank you.
Great. Thank you so much to Amanda and Carol. It's truly inspiring to see how evolved and sophisticated the task force members have become, methods have become, and we look forward to more conversation. I'm going to let us go ahead and switch gears at this point, and then we'll actually have about 20 minutes for discussion and questions from the committee at the end. So I'd like to introduce Dr. Carrie Klabundi. She is a health services researcher with NIH, and she currently serves as the Senior Advisor for Disease Prevention in the NIH Office of Disease Prevention. Welcome, Carrie, and we look forward to hearing from you.
Great, thank you. I really appreciate the opportunity to be able to present to the committee. So what I'm going to cover, and I am going to try to do this in about 10 minutes because I recognize with the agenda that we wanted to have about 20 minutes for discussion. So I'm going to shorten a few of my remarks so that I can cover this in 10 minutes. I am going to describe some ODP activities to engage NIH and the extramural research community in addressing Uspstf identified evidence gaps, describe some of the challenges that we've experienced in this effort, and then propose a couple of solutions that are based on our experience. So I am going to just fast forward here. So let me just say a few words. So there are a number of activities that ODP is fostering and facilitating to attempt to close some of these I statements. So David Murray had alluded to this in his remarks earlier on, but we have an annual I statement reporting survey that we conduct among the NIH institutes and centers. And this has two important functions. The first is it actually alerts the institutes and centers to I statements that are relevant to their missions and priorities. And secondly, we are trying to encourage and also monitor progress toward building research portfolios that address those I statements. And so we have seen progress as we have undertaken this work over the past 5 or 6 years. In addition, we will convene conference calls with ARC staff and representatives from the Evidence-Based Practice Center that conducted the evidence review for a particular I statement topic area. And the purpose of that is to go into some real detail about I statement research needs and gaps. We also, for certain focused topic areas, will pull together scientific meetings, workshops, or conferences. And that is a more in-depth attempt to try to develop a research agenda and discuss priorities. And one example of this took place in spring of 2019 was a trans-NIH workshop on the impact of screening in children on health outcomes. And then lastly, this has been mentioned that we do issue funding opportunity announcements, and we will build in some of the I statement, research needs and gaps into the funding opportunity announcements. But this it's not the easiest undertaking at times. And so I wanted to provide this example. This is a research needs and gaps statement for the I statement on unhealthy alcohol use in adolescents. And what I wanted to highlight here are some of the terms that can be a bit vague. There can be some lack of clarity, or you can have multiple interpretations of what some of these terms mean. And so just to reinforce that, the research needs and gaps statement, this is the main mechanism that the task force uses for communicating the research needs and gaps. So this is what NIH, program staff, and what extramural investigators would have, mainly to look at. So I'm not going to read all the bullet points, but just to say, a trial with an unscreened comparison group to determine the population level effects, more direct evidence, further test performance studies in various populations, evidence on important clinical outcomes, trials designed a priori to report subgroup effects in diverse populations, high quality studies. So you get the sense that some of this language would really be open to some discussion and interpretation. And so there are some potential gray areas for funders and investigators who would be interested in closing evidence gaps. And I'm just summarizing some of the things that we hear a lot, because it's my team within ODP that does a lot of this outreach work across NIH to have discussions about I statement evidence gaps. So, what is direct versus indirect evidence? What does that mean? What are intermediate versus health outcomes? What do you mean by population level effects of screening? What does the task force consider to be a high quality study? What types of trials are most needed, and what would be the size? Because of course, the size of the trial, there's a big cost factor in that, in terms of what an institute, what type of resource an institute might have to put into trying to design and support a trial. And one of the things that we hear very often from some of the institutes that we have been talking with is, well, this is a long list of identified research needs and gaps. And so we're not going to be able to address all of these. So which ones, if we were to invest in this, which ones are the ones that would be most likely to move the topic or the subgroup that the I statement pertains to off of the I? And so the list isn't prioritized, but we're often asked, well, what's the priority in here? And then we are often asked, well, where can I find more information about these research needs and gaps? So there are multiple places that one could go. So there's the recommendation statement. You can go to the Uspstf website for the analytic framework, for the research approach, for the procedure manual. There's the full evidence report. Maybe there are some other places, but the information is not all packaged in one place. So I'm just going to give a couple of examples of information that would be really helpful. So the first is the analytic framework, and this is for the unhealthy alcohol use topic. You would find this in the recommendation statement and in the evidence report, but it's really important because it shows the chain of evidence, it shows the type of evidence, and it gives the key questions. So this is an important information source. Another information source that would be really useful for further or better understanding the research needs and gaps would be the research approach. And this is just a summary. The research approach actually tends to be a much more detailed table. It can go on for a couple of pages. You can find this on the Uspstf website, but it gives the features of the included studies in the evidence review, and then of the excluded studies. And also what you can see under the categories is the PCOTS framework. So this is what the Evidence-Based Practice Center uses to structure the systematic evidence review. But so it's laying out what are the populations, what are the interventions, what are the comparators, what are the outcomes, what are the settings. But this is also important information for someone who is trying to understand the research gaps. The full evidence report could be another source of information about research needs and gaps. So there is a section in the evidence report, usually entitled Limitations of the Studies and Future Research Needs. In the particular example of the unhealthy alcohol use review, there is a lengthy 12-page narrative. There's a lot more detail in this section of the full evidence report than what you find in the brief research needs and gaps section of the recommendation statement. But the caveat is that this narrative really reflects the assessment and the interpretation of the Evidence-Based Practice Center investigators who conducted the systematic review, and it doesn't necessarily reflect the assessment and the interpretation of the task force when they reached the insufficient evidence determination. Nevertheless, especially if you're trying to get a better handle on what were the limitations of some of the studies in the review that led to the issuing of the I statement, this could be a useful source of information. And then there's the Uspstf procedure manual, and this is particularly important or useful for certain definitions and explanations. So one thing I would have to say as someone who tries to help interpret research needs and gaps, some of the recommendation statements for more of a research audience, is that the task force uses a specialized language. And so, they have certain definitions, they have certain ways that they are, describing and talking about evidence. And this is not language that is necessarily understood or is, accessible to, even to a research audience. So I think, that's an important point to consider. The procedure manual, while hugely helpful, also can take some time to dig through to try to find what you're looking for. So for a lay person, an extramural investigator or an NIH program official, this may not be the easiest place to go to try to find what you need. So this is just a summary of the different information sources on research needs and gaps. And so they're in different places. The information isn't really pulled together in one place. You do have to know where to go or what you're looking for, and it isn't a completely straightforward process. So there's the recommendation statement, which very importantly gives you the research needs and gaps list. But for the analytic framework, that's where you get the key questions in the evidence chain. The research approach will give you the PCOTS and the inclusion-exclusion criteria for the systematic evidence review. For the full evidence report, you can go there to get the Evidence-Based Practice Center's narrative on study limitations and future research needs. And then for definitions and explanations, you can go to the procedure manual. So in conclusion, taxonomy and structured approach to describing and reporting research needs and gaps would help funders and investigators in their efforts to act on them. There are some particular areas of information need, so specific populations to target, specific features and components of interventions and types of comparators, specific outcomes to assess, and then definitely more detail on study design, some guidance on what would be appropriate study features and especially sample sizes. The PCOTS framework could be applied or adapted to characterize research needs and gaps. So that might be something to for the committee to think about. And then also consolidating the information needed to understand the research needs and gaps would be of further assistance to funders and investigators. And I wanted to close with a comment about potential project impact. So certainly the tools and approach developed in this project will guide efforts by the task force, by ARC, by NIH to identify and address evidence gaps. But there are other groups, and Nico Pronk earlier on had asked about the Community Preventive Services Task Force because they also issue insufficient evidence findings. So there are other groups that review scientific evidence and make comments about or provide information about evidence gaps. And so this project actually may influence efforts by other groups, such as the Community Preventive Services Task Force, in their efforts to communicate and disseminate evidence gaps. So we do think that there's impact beyond the USPSTF work. So thank you.
So Carrie, thank you so much for that terrific overview. I'm going to actually open the floor to our committee members. I think that we've learned a lot from all of the presenters in this session, and it's great to get into more detail about how the task force thinks about evidence and some suggestions from the NIH perspective about how to think about evidence gaps and existing frameworks. So let me look to the committee members and ask that you go ahead and raise your hand virtually if you have a question. If you're not able to do that, put your video on and wave and we'll see you. Actually, maybe to get us started, because I know this committee always has a lot of questions, but I'll float a question that came up in conversation a little bit earlier, and this is about the overwhelming number of evidence gaps that do exist. And Carol, as you were displaying the some examples, I thought, wow, the task force is really trying to be very specific about what kind of research could be helpful. I think that one of the questions that the committee has is, should the taxonomy that we are developing attempt to help indicate any type of prioritization among the different types of gaps? And that can be a question for any of our speakers, but what I was seeing in some of your slides made me think of the question the committee had generated.
I'd be happy to take a crack at that, and certainly Amanda chime in with more details. I would say that in particular, the task force is quite interested in making sure that our draft recommendations are doing whatever they can to mitigate health disparities in screening. And if we were forced to prioritize which gaps might be very important to fill, I think we would have consensus among the current task force members that those gaps are critical to fill. And more importantly, we keep an eye out for unintended consequences from our current recommendations in the domain of health disparities. So for example, because onset of lung cancer happens at a younger age in some groups and with lower levels of pack years smoked, we had the unintended consequence that many Black males, when diagnosed with lung cancer, were never met the eligibility criteria for screening. And so both clinical trial data and new modeling data strongly influenced our draft recommendation that lowered the eligibility for screening in terms of the number of pack years and the age to initiate screening. And those two changes starts to mitigate that health disparity in screening. So, I think I would have to say that this is an area of great interest and concern, that the studies are funded that help us make sure that how we are putting the recommendations together are mitigating disparities, especially among the groups with the highest prevalence and mortality from many of the conditions we're screening for.
Yeah, and if I might add, I think Carol raises some really great points, and I think prioritization has many meanings to many different people. And I think, the task force and ARC it tries to also be sensitive to that. But I think where it may be really helpful for the committee is to give guidance on where to focus, how to organize, because again, there's different priorities out there for various different stakeholders, but helping some organizational structure and guidance to help the task force with the various gaps could be really beneficial.
Elizabeth has her hand up.
Yeah, thank you so much. I was just wondering about how we would consider what's going on now with algorithms and predictive modeling, in the potential or the growing understanding of how that's driving some disparities. So for example, recently there's been a lot of congressional engagement with my group at the Association of Black Cardiologists, asking us to comment on whether or not some of these algorithms should be discontinued because of the fact that sometimes it's, for example, in kidney disease, it may be delaying care in some individuals. And then because the data that went into generating those algorithms sometimes are incomplete, sometimes people believe that there are aspects of bias in some of their application. So I don't know, this may be sort of going a little bit far afield. And I was just wondering, how would we, especially if there are some recommendations that particularly some of these algorithms now that are being put forth, if there's insufficient data or a knowledge that there's an opportunity to drive disparities, how do we sort of weigh that into that incomplete or additional data required and stuff like that?
Arlene Bierman is actually waving her hand.
Yeah, sorry, I know this is not my session, but this is just more for a point of information, and then I'll let the presenters answer. But Dr. O'Philly, just so you know, ARC has received a request from Congress to conduct an evidence review on the impact of race and other factors that introduce bias into algorithms. And we will be putting out an RFI in the near future, asking the community for really information, because I think we've been thinking about it a lot, and it's really a challenging review to do, and there's probably no right answers and no hard evidence. So I didn't want to interrupt, but we really, I'd be happy to circulate the RFI when it comes out, and we'd love your input.
Dr. Ophelia, let me just take a little bit of a crack at that. I think that the task force and other stakeholders are really in need of comparative effectiveness research that looks at eligibility for screening and health outcomes when algorithms are used, and when simpler methods are used that might apply to the general population. And certainly when we think about something like lung cancer screening, there are more sophisticated algorithms than the one adopted for screening in our draft recommendation, but our modeling studies suggested that those algorithms didn't really strongly influence the health disparity in screening or other aspects of screening. But I think this is an area where we do need a call for research, and the more population-based high-quality data that we have coming from surveillance and coming from pooling electronic medical records gives us a foundational database to actually test different algorithms longer term. And I think you've pointed to just a really critical part of the research portfolio that we need more activity in to better understand.
This is an interesting and important emerging area, it sounds like. Bob Wallace has his hand up. Bob.
Hi, I'm not sure, Tracy, I'm not sure that there's a lot of time, but I wanted to ask a somewhat different contextual question about something as complex as what is primary care and what are the boundaries of it. I was a primary care practitioner here at the university, and I basically had to do everything. And I think the rule of the task force is you either do it or you refer it, which pretty much covers everything. And so I'm just wondering, is there some boundary around what primary care is? I mean, I think I know what it is, but I'm just trying to draw you out a little bit about some of the boundaries.
So I can take a first crack, and I think that's a great question. And I know at ARC there's actually been internal projects just looking at that. So it is a complicated, a good question and complicated answer. But I think in short, for the task force, when the task force is doing its draft research plans, it does try to be pretty inclusive of a definition of primary care, and especially when thinking about referable from primary care. But I think it's trying to look at whether the primary care clinician can have a role in seeing that population and making the recommendation, providing the service, or pointing that person to the service. So again, can that setting have it? So starting in that primary care setting, but who it is within the primary care setting really could be quite varied, and is in the research plans. But I don't know if Carol wants to weigh in more as well.
Yeah, I just think I would quickly weigh in to say that it's not the primary care provider at this point, but it's truly the primary care team. And when we think about implementing task force recommendations, I see the electronic medical record as a critical member of the team, and I think ARC has too. This is a tool that we can leverage to deliver a lot of preventive services that used to be, I'm a practicing primary care doctor too over the last 30 years. And, it used to have to be completely between, our ears and ability to keep it all straight and to do everything. But I think at this point, these are multidisciplinary teams delivering primary care, facilitated by a lot of technology, and we should be able to leverage this to do a much better job at getting the right services to the right people.
Thank you.
Great. I see that people are quiet, and I'll take this opportunity to say that it's been really a wonderful session. You all have, our presenters have brought so much to educate us with, and I think that we, the committee, are inspired by the perspectives that you've brought, and we look forward to more interaction with you going forward. So I think we're actually very close to the end of our formal time. This won't be our only chance to interact and ask questions, and I think that we'll look to Kathleen and to our National Academies members or staff to help mediate some of the further interactions that we will have. So again, thank you so much. It's truly an honor and a privilege to get to learn from you about the work that you do every day. And we look forward to working on this important project. So I'm going to let people go. I'll look at Kathleen and to the National Academy staff, and actually maybe we can stay for just a couple minutes after if you have time, and close the formal session by saying thank you to everyone for being here, and I look forward to our next interaction. Bye-bye.